Right. So, as I said, we are going to talk about objective structured clinical examination and objective structured practical examination, how to develop, how to execute both face-to-face and online. As a performance-based assessment tool, OSCE is being used in the exit examination of undergraduate medical students around the globe, including United States, UK, Canada. Almost all medical schools in Malaysia are also using OSCE in their exit examination. It's also used in the postgraduate high-stake assessment tool in Royal College, for example, Royal College of Physicians in UK, with the name of Practical Assessment of Clinical Examination Skills, or PACES. Not only for exit examination, but it is also being used for certification and licensure to practice medicine, for example, in PLAB, in Medical Council of Canada qualifying examination, in USMLE, and in FCPS as well. Apart from summative assessment, it is also being used in a formative assessment in undergraduate medical education, and not only that, for also teaching purposes with immediate feedback. Now, today's presentation is divided into three parts. The first would address the questions like what is OSCE, why it's needed, what is so good about it, what are its limitations, and then the role of OSCE in assessment of medical students. The second part would be construction of questions and setting and conduct of face-to-face OSCE, and third would be conduct of OSCE online. So we will cover all these three areas one by one. The learning outcomes for this session, the participants will be able to explain the rationale for preferential use of OSCE or OSPE, construct valid and reliable OSCE and OSPE questions, and organize OSCE or OSPE stations following prescribed rules, and conduct face-to-face and online OSCE or OSPE efficiently and effectively. And we will try to cover all these four learning outcomes. Coming to the first part, the introduction. OSCE is now 45 years old, was first introduced in 1975 by Harden, and it was meant to assess candidates' clinical skills, attitudes, problem solving, and ability of application of knowledge in one examination. If you look at it, these are all characteristics or attributes which are also examined in long case examination, the traditional long case examination. So basically, OSCE was there to replace the long case examination. And many reasons were given, and some of them may not be correct reason at present. And using the same principle, the OSCE was extended further and was used for assessment of practical skills in preclinical areas, the OSPE. So it in clinical area as OSCE and in preclinical area as OSPE was recommended and applied. The main principle or main characteristic of OSPE are two words: objectivity and standardization. The objectivity is achieved by standardized scoring rubrics. So we have checklists, and then using the same trained examiner asking the same questions to every candidate. So there is standardization at every step of the examination. And the aim was that with this standardization, we will be able to improve the reliability. OSCE assesses performance in the simulated environment, which is at the show level of Miller's pyramid, because the does part comes only in the real life clinical examination, like a long case and short case, but OSCE is showing how the students would perform certain actions or certain procedures in a simulated environment, which is at show level, but not at does level. The concept of utility index means the usefulness of OSCE from many different aspects. So a well-designed OSCE has a high level of validity, which means that it would assess what it is supposed to assess, and has high degree of reliability, means the results are reproducible in different situations with little error, and has a standardized station design assessing a specific clinical task, which is blueprinted against the curriculum. I'll talk about blueprinting in a short while. And then can drive learning and therefore can have a positive educational impact. The descriptive definition, which would tell the process of conducting the OSCE. Performance-based assessment tool based on the principles of objectivity and standardization. And here the candidates move through a series of time-limited or time-restricted stations in the circuit for the purpose of assessment of professional performance in a simulated environment. So to fulfill the requirement of an OSCE, we have to have this kind of infrastructure. And at each station, candidates are assessed and marked against standardized scoring rubrics by trained assessors. So we have to have time-restricted stations, each station assessing a particular task. Students move around. It is not a real environment, it is a simulated environment, and there is a standardized scoring system, and the same assessors are assessing where they have been trained specifically for this purpose. Now, another concept which we need to understand about OSCE, OSCE is not a test method like MCQ or essay. It is an organizational framework, and many different kind of tests can be placed on this organizational framework, which may be clinical skills, practical skills, procedural skills, lab tests, or communication skills. So this is a platform which provides us the opportunity to test many different aspects of clinical medicine in one go. Why we needed OSCE, why it was thought to be the better option. Now, there are 4 factors which can affect a student's or a candidate's performance. If we are talking about a long case or a short case, real life clinical examination. One is patient's performance. Second, examiner bias. Third, non-standardized marking scheme. And the fourth is the candidate's actual performance. So unfortunately, of course, the most important element here is candidate's actual performance, but that performance is being affected by a number of other factors, which are out of control of the candidate and are not relevant, like the patient behavior. The patients may have different behavior with different students under different conditions, examiner bias, and the non-structured or non-standardized marking scheme. So there could be inter-examination examiners' differences in opinion. So OSCE was brought in to reduce the number of variables. Means using standardized patients would reduce the patient's influence. Same examiner, so examiner bias would be reduced, and standardized marking schemes means there would be little difference between marking among different students. So this is what we expect from an OSCE. A well-designed OSCE, the grades of the candidates should predominantly be affected by the performance of candidate alone, and with minimal effect or confounding effect from other factors. That is the point, a real strong reason for OSCE to be accepted so widely across the globe. If we look at the long case, the traditional long case examination and what were the issues involved in that, one is we know that the candidate's interaction with the patient, including history taking and general communication, is not always observed. The student is communicating and examining the patient in the absence of the examiner, and examiner comes only later. Second, the marks awarded for long case are based upon unstructured questioning rather than checklist or standardized scoring sheets. So actually, we can improve our long case examination by using observed long case examination, which some of medical schools in Malaysia are doing, especially the end of posting, and second, standardized marking schemes and rubrics. The point here is that it's not necessary to really discard long case from the examination, as long as we can improve on some degree of observed long case, and if we can use some standardized marking schemes which are available from number of institutions. The other aspect, which is one of the issues in long case examination, that many times the examiners, they start asking theoretical questions because the clinical component is finished very quickly, and then to fill the time, the examiners start asking theoretical questions, exploring the depth of candidates' understanding, that is their knowledge and management plan, which is not really part of a long case examination, and these aspects can be easily examined during written examination. So this aspect can be covered easily by training of examination and blueprinting clinical methods, interpretation of findings, and avoid theoretical questions. So examiners can, in a short briefing, can help to manage this issue. So that is the OSCE and the long case. Now OSCE and the short case, the issues which we see in the short case is that patients often change between candidates. So not every candidate gets the same kind of patients, and as we see that some students get relatively easy cases, others may get relatively difficult cases. So there is no standardization of examination in the short cases. The reproducibility and validity of these examination is affected by unstructured questions by the examiner. So there's a lack of standardization. On the other hand, the argument is that using different patients is the realistic real life situation. In real life situations, we don't get the same kind of patients with similar behavior and similar signs. So doing short case examination is really a realistic situation and has edge on the OSCE in this aspect. And again, this we can use the standardized marking schemes to cover the second part. So again, the point is that if we want to retain both the long case and short case, in my opinion, we can still retain with little bit improvement and little bit of training. And there are strong reasons to retain this kind of examination, which I'll talk in a short while, especially in developing countries. So in summary, the drawbacks of long case and short case examination, like intercase variability, a single case does not allow the assessment of candidates' performance. Yeah, this is another area, because to get reliability, the number of cases needs to be increased. So just one long case may not be enough, but we have a solution to that. The content specificity of long case makes the generalization of skills assessed using this technique nearly impossible. So we cannot generalize our conclusion from one case. But if we start counting our end of posting clinical examination as a part, let's say as a continuous assessment part of exit examination, so most of these points against long case or short case can be covered. So, for example, in our final year, there may be 5 or 6 postings in medicine, surgery, pediatrics, ONG, psychiatry, etc. And we have end of posting clinical examinations. So if these clinical examination consisting of long and short cases, they can become the part of the continuous assessment. So then we would have enough number of these cases to make it a reliable method of examination. The third part, Viva OSCE examination, it is basically a recall of and depth of knowledge and hypothetical problem solving judgment, clinical reasoning, and analytic skills. Again, the issue is unstructured questions and the poor iterator reliability. Again, these aspects can be covered by using a structured Viva and for example, by using MEQ. Now, the point I'm trying to make here is that, of course, OSCE is a very useful alternative in these situations, but OSCE has its own limitations, which we will elaborate in a short while. So if we want to retain the long case and short case examination, we can still do that with appropriate changes. Now, OSPE or OSCE, there are a number of variants. So from OSCE, it has changed to a number of other formats like OSPE, the objective structured practical examination, then objective structured assessment of technical skills, then objective structured video examinations, then team objective structured clinical examination, and there are many more. So this, as I said, that OSCE is actually a platform. It is not just one method, and it can be applied to a number of situations. Now, here is another interesting point, that while candidates are appearing in the clinical examination under observation, their behavior may not be the real actual behavior. They may have a different or controlled behavior under supervision during examination, whereas the actual performance or actual the behavior may be different. So there are methods to cover both aspects. So actual performance can be assessed what is called the 360-degree assessment, whereas observed performance can be covered both through clinical examination, long case, short case, are under OSCE. So this is another aspect where OSCE can play a major role. As I have mentioned earlier, that OSCE assesses the student at the show level and not at the does level of Miller pyramid. Now, coming to some limitations of the OSCE. First, as I said, it is at show how level. It is not at does level, whereas the clinical examination, long case or short case, would be really at the highest level of Miller's pyramid. Second, it is in simulated environment, and simulated environment itself can influence on the student's performance. Many of us will forget to greet, smile, or introduce ourselves to a mannequin in real life. And this is what we expect from students to do. So it is really does not reflect the real life situation. In real life, non-clinical skills such as team working, resource management, situation awareness, leadership are tested, which is not possible in OSCE. Just imagine examination of a real infant in the ward as compared to examination of a small mannequin. So they are not comparable at all. Another limit of OSCE is compartmentalization, where we are assessing certain skills in isolation. For example, pap smear on a model, which becomes a very mechanical exercise, whereas if it's being done on a patient, then you have to take a lot of precautions, the communication skills, the knowledge, the attitude, the ethics. So all those aspects are neglected due to this compartmentalization. So basically, we are dividing the patients into small components, small parts, rather than examining the patient as a whole. OSCE should be designed to assess competencies or skills which cannot be assessed using pen and paper, but most of the time we do see that maybe the first question is a skill or a procedure, but rest of the questions are based on the theoretical knowledge, which is not really a good OSCE. Consider, for example, a station designed to assess a candidate's ability to interpret a radiograph. So we use the X-rays are used in OSCE where there is no examiner and there are structured questions and students have to answer those questions. That may be easily tested in other methods more reliably and more cost effectively rather than in OSCE. So the big issue here is that the poorly structured OSCE stations may lead to candidates learning skills to pass the examination rather than to improve their clinical skills or clinical performance. And this is mainly due to compartmentalization and assessing certain skills in isolation without proper context. So summary of limitations is an unrealistic simulated environment. There is a fragmentation or compartmentalization. There's a minute checklists, and many times examiners get distracted. They are more concerned to fill in the checklist rather than looking at the candidate. And role of the examiner needs to be defined for each station. For example, if students seems distracted or lost, and so how to intervene. Then if we are using the simulated patients, the extensive training is required, and the expensive high fidelity mannequins are required, which may not be possible for resource constraints with institutions. So how we can use OSCE with all its limitations as well as the advantages is that it can become a part of test battery approach, where an ideal summative assessment program needs to be based on combination of assessment tools. So OSCE can be a part of these assessment tools rather than replacing these assessment tools. The one way could be that we have OSCE, we have long and short case with structured marking schemes and continuous assessment, including end of posting long case, short case examination and 360-degree assessment. So in this way, we can cover the deficiencies of each component with another method of examination. So OSCE is best used for communication skills, for example, counseling skills, health education, obtaining consent for a procedure, or for procedures like intubation, CPR or intravenous line of on mannequins, of course, keeping in mind the limitations, and then clinical examination on mannequins with communication with simulated patients. I'll give some few examples about this in subsequent slides. So, conduct of OSCE, as we see, it's is a circuit where students rotate. The important point here is that OSCE is a skill-based or clinical-based examination and not a theoretical-based examination. So to make it purely a clinical examination, we need blueprinting, means that appropriate spread of sampled capabilities, different systems, different domains. We must make sure that we are not repeating the same things again and again. And there must be a constructive alignment. The outcomes, the curricular outcomes are being aligned with the assessment in the OSCE. Of course, valid and reliable, authentic questions, and avoid unnecessary duplication. For example, same condition coming for the nephrotic syndrome in the written examination, long case and short case, and again in OSCE, are same systems. Respiratory system in written examination, long case, short case, and OSCE. So if we have a proper blueprinting, we can avoid this duplication. So blueprinting before the construction of OSCE and after the construction of OSCE during vetting is a very useful approach. So one suggestion is that the sequence. So we have a list of conditions which we think the students should be examined. It might be an exhaustive list, but from that list, we first choose the conditions which can be examined as a long case. So usually chronic cases with clear history, well-investigated patients, but not necessarily having a clear physical signs, for example, epilepsy. So there may not be any physical sign, but there would be a good history and the investigation results. The clinical component can be covered mainly in the short case where the patient must have a physical sign and it is a focused examination. Then those things which have been covered in long case and short case should not be repeated in the OSCE. And it can be procedures like peak flow meter or pap smear or lumbar puncture. Communication skills, for example, explaining the investigation results, using growth charts, plotting and interpreting, or using audios and videos, which especially the conditions which we may not be able to show in the long case and short case. Then comes the written part, and we use the structured essay questions, maybe short essay questions or modified essay questions. And these should cover mainly the pathophysiology, emergency scenarios, the data interpretation, analytic skills, and decision-making skills, and then comes the multiple choice questions. So if we follow this scheme, this sequence, and keep on striking the areas which are being covered in each of these components, so we can avoid the unnecessary duplication. Planning and preparation, so it is quite a big exercise. The administration role, venue, resources, specimens, movement of equipment, meticulous organization, laying down the plan, construction of stations, signages, running the OSCE, the timekeeping, rotation, movement of students, changing of standardized patients, breaks, and then issues with multiple sites, multiple cycles. So it is really, really a very meticulous planning. Then is the training of standardized patients. It's not easy. We have been through this, and many times the things don't go the way we want it to go. Then training of examiners, valid and reliable questions, and appropriate scoring rubrics and briefing of students. So this clearly explains that OSCE is not an easy examination and really needs meticulous work and a teamwork to manage that. Then the OSCE station writing template. It is a good practice to have a similar format for all the OSCEs, so that helps in bringing the reliability in the scores and also for banking purpose of these questions. So you can have a title page and instruction for standardized patient, instructions for students, instructions for examiners, and marking rubrics or marking schemes. So this is one suggested template to construct OSCE questions. What is the minimum number of OSCE and what is the duration? For practical purposes, when we are running OSCEs, there are a number of factors which would influence our decision in terms of number of stations. For example, we need to have a minimum number which can give us a good reliability, at least around 0.8. And then we have to see whether this is feasible and then we have enough resources. So it is recommended 14 to 18 stations with 5 to 10 minute duration. So a total time may be between 2 to 3 hours. So this is a minimum requirement for an OSCE to be a valid and reliable method of assessment. We need to define the role of examiner on OSCE station. The examiner is not a fly on the wall, and I choose this sentence because at number of times I have heard the examiners being told that you have to act like fly on the wall, just observe and don't interfere at all. But that is not true. when we are conducting these examinations, we do see that the examiners need to play their active role, especially in time management. And for example, in counseling skills, you may have 10 questions on the list, whereas student is spending maximum time on the first question. So we need to handle these situations actively. And if there are any clarifications or queries by the students, the examiner should be able to answer that. Now, the types of OSCE stations. One is the observed station, probably the best type. An examiner is present throughout the duration of the testing. Examples like communication skills, procedural skills, clinical examination. Benefits is, of course, direct observation, which allows the assessment of higher level of learning domains, and immediate feedback can be given if it is a formative assessment. But of course, it is resource intensive. So for each station, you need an examiner. If you have, let's say, 18 stations in one circuit, so you need 18 examiners. And many times we need to have more than one, and sometimes several circuits. Then is unobserved station, where of course no examiner is present throughout the testing period, and answers may be submitted on the paper either after each station or following the completion of the examination. Examples like interpretation of clinical information, X-rays, pathology specimens, blood results, prescribing skills, etc. Benefits: examiners are not required on each station, so less resource intensive, but the limitation is there is no direct observation of performance. And actually most of these assessment parts can be done successfully and effectively, and maybe cost effectively in other ways. However, talking about OSPE and spotting, which is used in certain medical schools, they are a good example of unobserved stations, and because they are really not clinical, they are just practical, and where the observation may not be very necessary. The third is technology enhanced stations. These are the high-end mannequins with additional features. Examples like CPR or complex decision-making skills and the management of acutely unwell patients like arrhythmias. The benefit, of course, is allows assessment of learning domains which could not be assessed effectively using traditional OSCE stations, but it is a very expensive, at least the first investment needs a lot of money. And the personnel must be trained in the use of equipment. Equipment failure is a possibility, so backup is needed. And as I said earlier, the high initial cost of new equipment, and on top of that, the maintenance cost. So it is not easy to have this facility in resource constrained situations. Linked station is another type where two stations are linked, based upon the same clinical scenario or information. This may be a combination of observed and unobserved, meaning one is observed and other is unobserved. Examples: the observed examination of respiratory system in the first of the two stations, and in the second station, the student may write all the findings and the management plan. So this gives more time for completing a good clinical examination. Benefits: of course, a greater number of skills can be assessed and efficient use of examiner resources. but limitation is that we have to have very careful planning, because we cannot start the circuit with the second station and cannot finish on the first one, because both stations need to be covered. Right. Now, the next aspect of OSCE is marking and pass-fail criteria, and that is what is the standard setting. So standard setting refers to defining the score at which a candidate will pass or fail that particular station. The norm reference method, where the scores are compared among the candidates, is not really an acceptable method for clinical examination, because if it is a cohort of so-called poor students, the one candidate may pass in this situation, but if it is so-called the strong cohort, then they may not pass that. So it is not really a reliable method. The criterion reference is more reliable, and where the scores have absolute meaning. And so NCOF and ABLE are two commonly used methods for this purpose. This means that if we want to do the standard setting, we should not be using the norm reference, but we should be using the criterion reference method if we want to use the standard setting method. And standard setting is done before the examination and not after the examination, by a group of experts who look at each item test to determine its difficulty and relevance. Now, global rating is another way and useful in standard setting. As we know that not every thing can be tested by a checklist. The overall impression of an experienced examiner has a very valuable role to play, and that leads to what we call is the global rating. However, using global rating alone in the absence of content-specific checklist would bring in the subjectivity, and which is exactly the problem which OSCE is supposed to address. So global rating alone without checklist is not recommended. So we have to use both the checklist as well as global rating, and then using this information, we can use the standard setting by what is called the borderline regression methods. Borderline regression is considered the best method of assessment in OSCE examination. Examiners are asked to award a global score in addition to checklist. So apart from using checklist and giving marks there, the examiner is asked to give an opinion, maybe one of 4 or 5 options. There is a student is fail, is a borderline, is a pass, good pass. So irrespective of the marks given, the examiner gives the opinion. In fact, it is advised that the examiners don't add up the marks, because that can influence their global rating. So they just give the marks on the checklist without adding. And without adding, you can give the impression. And we all know as examiners that sometimes we say that this is such a poor student and I don't know how he passed the examination. So we have to have a global rating as well as the checklist. And when we have these two, so we can use this information to draw what is called the borderline regression and using statistical methods. Here is an example. There's global rating is at the x-axis, whereas the station marks are at the y-axis, and then they are plotted and a line is drawn, and wherever it passes through the borderline, that makes the pass marks. Here is another example. So here, for example, here we say borderline, but our marks are above the passing level, right? Here we say the borderline pass, but our scores are really, really high. So there is two different things, the scores and the global rating. And by this method, we can combine the two and come up to a reasonable passing score. So for example, in this case, the passing score can be 19, although your scheduled may be lower or higher than this. So this is a good way of really getting a reasonable marking approach. The NGOF and borderline regression procedures provide reasonable, and the good thing about this is that we don't need really special statistical training to apply these methods, and they can be applied by non-psychometricians in medical schools. Now, next important question is the compulsory pass stations. How many stations or what percentage of stations student must pass to declare them pass in OSCE, or it should be the total marks. So there are a number of different suggestions. If we are using programmatic assessment, so this means the number of stations doesn't matter because the marks are being distributed according to different attributes like communication skills, etc. But if we want to have pass or fail on each station, then we have to see that there are certain crucial points where a student must pass. If we combine the marks, so the student may fail badly on a CPR station, but may have a good marks in communication. So overall student may pass, and that would be really a mistake by compensating CPR with communication skills. So the one is that students should pass overall. These are few suggestions from the literature. So student must pass overall, but there should be some stations which they must pass. For example, with overall marks, student must pass these 4 or 5 stations. There is another method that in certain situations, multiple skills are assessed on the same station, like clinical skills, communication skills, or analytic skills, which is more like a long case examination. And this is being used in USMLE step 2. So the candidate is supposed to pass in all the 3 or 4 aspects which are being examined on one station. The other suggestions, one is that percentage of stations required equal to aggregate cut score percentage. If pass marks are 50%, then must pass 50% station, which is actually, if you look at carefully, there's already 50% pass score and then pass in 50% of stations. So that really lowers the standard of clinical examination. Similarly, another suggestion in literature is identify a borderline group at examination level and calculate their typical number of stations they passed, and then either their maximum number or average. Again, this would means the lowering the standard of the examination, unless the sample size is really quite big, which can cover many confounding factors. Use logistic regression to predict pass-fail decisions at the station level and calculate the probability that a candidate with a borderline grade would pass the station. And then is the regress station passed on total score. Here is one example. Let's say the pass, your cutoff score is 300, and let's say maybe out of 600 or 450, and then you find the number of students who have passed at a number of stations who have been passed on this point. That can be used as one method. So these are our different suggestions, but none of them is really a final recommendation. We will come to our own conclusion towards the end of this presentation. So with that background, the theoretical background and the different methods of looking at the OSCE, coming to real issue, how to conduct face-to-face OSCE. I'm sure many of you are familiar with this, that we have a circuit of stations and students rotate around. And this can be, the procedure can be history taking, can be physical examination, can be counseling, can be video with scenario. And there is a time limit on each station. The ring bells and the student moves from one station to another. And the observed station, the examiner marks or assesses the students, and unobserved, the student answer the questions and leave the sheet, which will be marked later. So that is face-to-face conduct of OSCE. Now, under the present situations, the pandemic, the online conduct of OSCE has become an important part of assessment. So this can be done. Just keep in mind the example of telemedicine. So how we advise our patients using telemedicine facility. So same concept can be used for conduct of OSCE. So designing and running an OSCE on the Zoom platform requires meticulous planning and preparation. It is important to recognize the limitations. Of course, many of the physical examination skills cannot be assessed in this format. And we may have to run too many circuits if the number of students is large. But what we can do is that use the breakout rooms feature of the Zoom, and then student can be moved from one room to another, and examiner and students can share the screen. So this facility is there. So we have a breakout room, and in that breakout room, the student is there, the examiner is there, and the patient, whether simulated or real patient, is there in that room. Although they are on different locations, but everybody is virtually present in that room. And we use WhatsApp for secure communication, and allocate rooms to examiner and real or simulated patient, as I said earlier, and make student co-host, because making student co-host then allows them to move to the next room, and they distribute students in breakout room. This means that the one controlling person is present on the main platform, whereas students, examiner, and patients are in their breakout rooms. And by using the broadcast facility, the person in charge can direct the students to move from one room to another. So with the limitations, this can be a very useful method. We can have a history-taking station, whether from a real patient or a simulated patient. We can have an audio with a scenario. We can have a counseling station. We can have a video with a scenario, or we can have data interpretation with scenario. I'll elaborate a little bit more in the next few slides. For example, the history from the patient, whether it's real or simulated, is taken, and then physical examination findings are provided by the examiner, and student is asked to interpret. Communication with the standardized patients and performing procedures on the mannequin. This is happening in face-to-face examination as well, that the procedures like pap smear or rectal examination, what the actual procedure is done on the mannequin, but a simulated patient is sitting there. So you communicate with the patient, but you perform procedure on the mannequin. Communication with the patient and investigation results are provided by the examiner, and then the subsequent questions are asked. For example, history from the patient, ECG shown by the examiner, and student interpreting and answer the predetermined question. So because the patient is virtually is there, student is there, so they can communicate with the patient, and then the examiner can show the ECG and the relevant questions can be asked. Similarly, history from the patient, and then we can have some audios like breath sounds or murmurs, which examiner can provide, and then similarly, the student can be asked to interpret and answer the questions. The third is the history from the patient and the video, for example, of fits shown by the examiner, and the students are asked to interpret. So these are the different possibilities which can be used under present circumstances when we have limited access to the patients. So here are a few examples which can be used for the videos, examples of videos which can be used online, like fits, whooping cough, stridor, asthma with wheezing, achondroplasia, developmental assessment, abnormal gait, hyperreflexia, tremors, or finger to nose test. Then certain audios can be used like heart murmur or respiratory sounds like crepitations, rhonchi, wheezing, stridor, or croup. The other stations for online OSCE, for example, focused history can be done very successfully. Counseling can be done successfully. For example, a Down syndrome, compliance to medication, on discharge for severe attack of asthma, or thalassemia, or G6PD, or failure to thrive. So these can be done quite successfully online. Breaking bad news, taking consent, prescription writing, or calculation of fluids, or data interpretations. Of course, there is some compromise that there may not be real clinical skills being examined, but this is maximum we can achieve from online examination. So limitations of online OSCE, primarily the process can be organized simply, but it becomes a big issue if number of students is large. Then a lot of meticulous preparation is required, and a lot of manpower is required for producing documents, setting up WhatsApp group chats, preparing and briefing individuals, and recruiting the logistical workforce required to run the OSCE. So concluding remarks after all the discussion and different aspects. The first thing we realize that clinical practice is multidimensional highly complex entity, and designing a performance assessment which tests all these domains of practice is not an easy task. It is really a difficult task. And OSCE is one of the components of battery of tests and not for replacing the other clinical examination. And main reason for using OSCE is for its objectivity and standardization. As I said earlier, the OSCE cannot replace the benefit of long case and short case, but combining the two can cover each other's deficiencies. And by using multiple examiners, rubrics, marking schemes, the long and short case examinations can be made relatively objective tests. OSCE stations should comprise of procedures which cannot be tested in any other format. For example, insertion of nasogastric tube, videos of episodes which are unlikely to be seen during other formats like whooping cough or status epilepticus, audios of episodes which are unlikely to be seen during other formats like stridor, focused history, counseling, breaking bad news, taking consent, and prescription writing. And student must pass all these stations because these are all critical skills. So this means that we must choose the tasks which are really critical, which are core areas to be tested, and then we expect our students to pass all these stations. With that, I thank you, and I'll be happy to answer if you have any questions. Yes, sir. This question is residence as.
Can I ask a question, sir?
Yeah, yes, please.
Sir, my understanding is that if a student passes 50% of the OSCE stations, should they be declared pass in the overall exams?
So that is actually what I was discussing, and it's the policy of the institution. But if the point I said that if your pass marks is already 50%, so that is already 50%. On top of that, you are asking 50% of the stations passed. So imagine what level of clinical skills we are talking about. So if there are 20 stations, we are asking students to pass only 10 stations and each station with 50% marks. So that really brings down our standard. So my recommendation would be that we make the OSCE real OSCE, bring real critical issues, and require the students to pass all the station. Now, your passing marks, you may have, like you said, 50%, but at least you are asking them to pass all the stations, not 50% marks with 50% stations.
Yeah, so we have the same policy in our university that the student have to pass each station.
Yeah, I think that is the minimum requirement we must fulfill.
Yeah, so I've been to a course and they say that there's any unobserved OSCE station. The OSCE station has to be observed in any way. What are your thoughts about?
No, absolutely right. Absolutely right. Actually, what we have been doing, because we do not have enough resources, so we have been trying to cut down here and there and bringing actually some of the OSCEs which we are doing are not really OSCE because there's no clinical skill. It's just the data interpretation or
C1 level, C2 level.
Yeah. So I think you are absolutely right in that. If we want to use OSCE, we should be using real OSCE and not just satisfying ourselves by calling them as OSCE.
Yeah, sorry to keep you a long time.
Okay.
My other question is that we find as a clinician very difficult to examine the psychomotor skills of the students during this COVID epidemic or
Right.
pandemic, shall I say.
Right.
So I don't know what kind of product we are going to produce, because it's been about 1.5 years now, nearly 2 years, and the students have not been able to perform because of the less patients in the hospitals, because of the less attendance of the trainees in the workplace or the hospitals. So I don't know how to overcome that.
Sir, we are even in worse situation here in Malaysia. Our students have not been able to see the real patient for more than a year. So it's going to be really a difficult situation. The one way of thinking is that these students, they do not want to retain them for longer period of time in the medical schools. But once I hope the situation gets better and they start their house job, probably they would increase the length of the house job to compensate for the deficiencies which could not, the aspects which could not be covered during medical school. So this is one way of thinking. Otherwise, you are absolutely right. So we would have medical graduates, but not doctors.
Right. The one concern among must be all of us is that the online examination can encourage the students to consult the other people, or maybe the other side of the screen, somebody else is sitting and answering these questions. So that element is always there. Do you understand my
No,
point?
sir. We have conducted online examinations, and we had certain ways of doing it. And for that, I'm quite confident that these written examinations we have done actually quite reasonably good. We use the two devices, which means we use the Zoom platform with two devices, giving two views of a student, the side view and the front view, and we had the room screening. I mean, the whatever we can do through these onlines, and I think we were able to do it quite reasonably good, the written examination.
Thank you very much, and greetings from Pakistan. It's very nice to hear you, and it was very beneficial. Thank you very much,
sir. The other question is resident as simulated patients. Our examiner as an SP, yes, these are different ways. But when you look at the situation, the student knows that the simulated patient is an examiner, then the way of communication, the way of asking questions, that would not be real, like dealing with a real patient. It would become, in itself, become simulated. So that is one aspect that is going to be lost if we take this approach. The second question is OSCE template sample. Yeah, I gave you the 5 elements, but maybe later on I can share one template. Viva station in OSCE is why we need to use OSCE for Viva. I think OSCE should be for clinical examination, and whatever we want to examine in OSCE can easily be done through other stations. I don't think we need a separate station of Viva in OSCE. The next is student should the student be aware of? Because the marking scheme breaks down the one component into smaller components. So actually, if we give this scheme to the student, then student would exactly follow that one line by line. So it would be more of guided kind of examination rather than looking at the capability of the students themselves. Yes, sir. Any other questions?
Sir,
Salam, Prof.
Yes, please.
Dr. Amila here.
Okay, Dr. Mir, I'll come back to you in a short while. So Dr. Amila, yes.
Okay, I just put my question here in the chat box.
Right.
I have one question actually. Is there any possibility to modify the traditional OSCE from compartmentalized type into structured short case, which could include more than one compartment? As we can in this time, we can minimize number of stations on the same time. These small number of stations will be integrated and cover all the related learning outcomes.
Yes, that is actually being done in USMLE. That's
why
what
why can't
so,
we?
Yeah, I think if we can do that, that would be, so it would be, in a way, it would be a sort of modified short case.
Yeah.
And I think that would be a good, as it's being already done by USMLE step 2. So you can, in one station, you can assess number of different attributes.
Yes. So is it doable to be done as in final year students instead of doing a compartment? So can do multiple compartments as a whole so that they can assess patient as a whole instead of just multiple compartment.
Yeah, absolutely, absolutely can be done. But of course, you need to work around that.
Thank you.
Yes, yes, Mir Ali Shah Sahab.
Sir, assalamu alaikum. Thank you very much for very interesting, very critical discussion. And my suggestion is that we were happy that OSCE is going to replace the long case. As you know, in our exam, I'm examiner of CPSP, College of Physician, Pakistan, for a long time. And we have long case of 1 hour, 4 short cases of 10 minutes each, and OSCE in clinicals, apart from the theoretical exam. So we need your opinion. Can we replace? We were happy that so many stations will be going to replace the long case, but at the end, in the conclusion, you nicely said that it cannot replace the long and short cases. It's okay, not the short cases, but the long case, as you know, in many of the overseas exams, there is no long case in FRCS and MRCPs like that. So we need your opinion about what should be the duration of and the number of short cases to replace the long case. As the long case, the bias is there, the theoretical knowledge is there, the time, 1 hour duration is a long time. So how many cases of short cases and its length duration will you advise to stop the long case?
Right. Okay, sir. I'll go one by one. As you said, that OSCE is being used in number of developed countries, and they have number of reasons for that. Number one is the availability of real patient. In developed countries, with the limitations of availability of patient is a big issue, and then the human rights and the confidentiality, number one. Number two, having resources for high-end mannequins. If you have a mannequin which can have all kind of heart murmurs and respiratory sounds and can they give the feedback, then of course if you have that kind of resources, yes. But in a situation where we have very restricted resources, we cannot invest so much on these high-end mannequins, and having the luxury of availability of real patients. It would be really a shame that if I have an access to real patients and I'm not using that and I'm going for mannequins. So I think I have tried to present this case that we must maintain long case and short case and add OSCE to that. But the major issue is that one long case may not be really a reliable method. But if we have, let's say the students are being trained in certain institutions and they are going through different examinations, and we bring along their previous performance then and add all these long cases, then it can become a reliable source. Now, your other question, yes, history taking can be examined in OSCE on the focused history, but physical examination, of course, we would need the short cases. So at least the short cases should cover all the major disciplines. What we call is comprehensive examination, that we have one long case from one of the major disciplines, and then at least three to four short cases from disciplines which excludes the long case. So that is one way we are doing it. I hope that answers your question.
Sir, one thing more was that what do you recommend if we replace the long case with the short cases, and the short case duration is nowadays 10 minutes. So do you suggest to increase the duration of the short cases to 15 and can include 2 more short cases in place of long cases? Is it?
You see, sir, the aim or the outcomes of 2 examinations are different. Short case is mainly looking at the clinical skills and the positive findings on physical examination. Whereas the long case is more of history taking and communication skills and all that. I do agree that history taking can be a part of OSCE, but then you have to have at least all major disciplines of long cases, short cases. But increasing the duration of each short case, I'm not sure whether that would be useful, because you want to do a focused physical examination. And what really happens is that the real examination is over in few minutes, then an examiner start asking questions which may not be really part of short case. We are not supposed to assess the theory and other components in short case. So if you can examine adequately in 10 minutes, let's say chest examination or abdominal examination, I think that should be the approach, because giving extra time is actually not beneficial to the student as well as to the examiner.
Oh, thank you, sir. Grateful.
Thank you. Yes, Prof. Soso?
Yes, I put in the chat. Can I ask how to conduct the counseling online? You remember, like breaking bad news, a Down syndrome baby born to the parents. That is my first question. And second one, I caught hold of somebody saying about the using 2 devices in the online examination. Currently, we are doing the theory online examination, 2 devices. One device is for the student to the laptop to access the Microsoft forms that the regulator had sent to them. They open and they answer it. That is the theory. And then the second device is the handphone camera focus on them. So invigilator, we have one invigilator, 7 students, 9 invigilators for 60 students. So each of our invigilators also regulator to it, so that I can look at 7 students. And what do I look? I look at their keyboard and their hands, what they are answering, and the screen is there, so that, and the table beside is all clear. So I'm invigilating
Professor, we have done exactly the same.
No, that is for theory. Now I want you to please advise me for the counseling where, how to do it. I want to access.
Now, if you are using the Zoom and you are using the breakout room, so examiner is there in the breakout room, student is there in the breakout room, and the simulated or real patient is in the breakout room.
Yes.
So then it's like you are, all 3 of you are present in one room, like in physical OSCE, and it follows the same way as you are doing face to face. So it follows the same pattern.
Yes. The online, because I'm concerned with the counseling doing online, because now
I think it can be done successfully.
Thank you. Thank you so much, Prof.
Thank you. Yes, any other question or comments? There may be some questions in the chat box, which we will try to answer later through WhatsApp if they have not been addressed now. And yes, please.
Assalamu alaikum, Prof.
Wa alaikum assalam.
Yeah, Tajmul here. I just want to ask, in this current pandemic era, when we are doing OSCE, just say we are doing face-to-face, but we have difficulty getting real patients.
Right.
Our patients, we use about 12 to 16 OSCE stations, usually about 50% are real patients.
Right.
Just say I put a cardiovascular station, assess the students' examination skills, but it is a limited patient. Can I also add on audio of the murmur that I want student to appreciate, and ask the student what is the possible murmur?
Right. Yes. I think that's what I was suggesting. That seems to be a good approach. That you can see the student. Now it's a simulated patient. Of course, we cannot have signs there, but you can see their technique of examination, and then you say, okay, you use an audio and show and say that, okay, this is the murmur which is audible in pulmonary area, for example. So I know it's not ideal. I know it's a compromising under present situation, but I think that is one way to at least to get some clinical input. So using simulated patients with audios, maybe respiratory sounds, maybe cardiac sounds. So that can be one method. Actually, we have been using even in face-to-face, where we, for examinations like, for example, pap smear or rectal examination. So we have a mannequin and we have a simulated patient. So student talk to the simulated patient, explain the procedure, reason why he or she is doing, but then the procedure is done on the mannequin. So I think that's one way of handling the present situation.
Thank you,
Prof. Ruptinder. Prof. Ruptinder.
Yes, good afternoon.
Good afternoon.
Thank you for your very illustrative talk. Coming back to the question was this, that standardized marking pattern.
Yes.
That could be part of the teaching time, that it can be shared with the student, that this particular performance station will have the following points to be highlighted when you perform. So if they miss out on those, then obviously they should lose marks, rather than they lose marks on certain additional points which are added and student is not aware of. This is what I was trying to highlight that
Right.
if the standardized marking plan is known to the student in advance, not during the exam, it is part of the training and teaching, and when we demonstrate a particular counseling setup
Yeah,
or
I think that's fine. I think that's a good suggestion that students, we are not telling just before the examination, but when we are training them for OSCE, I think that's a very good suggestion. That would help the students to, and also help the examiners, because we are sitting there and wondering that our checklist says something different and student is doing something different.
Exactly. That's what brings this to my mind, that checklist should also be shared with everybody for the person facing this. Thank you.
Yeah, I think, for example, we can tell the students that when we are assessing the counseling station, what are the components we are assessing?
Exactly. That's what I meant.
Yeah, no, that's part of the training of the students. I think that is a good approach. Professor Dr. Iram Iqbal.
Yeah, Assalamu alaikum, sir. My question is, what should be our approach while designing OSPE for the basic sciences students?
I think the OSPE is relatively easy and simple. I remember when I was medical student, we used to have this spotting on histology slides, and we can have the anatomy specimens marked, and students move around and let's say identify the specimens. Only issue which I see most of the time is that we have one or two practical things, but then we end up asking a lot of theory questions. So if, for example, we can have one station for urine testing, or we can have a slide looking at the slide or slide preparation, or there could be a pharmacology. So I think OSPE is much more easier as compared to OSCE.
Sir, actually, for basic sciences, we don't have long or short cases or history taking. Don't you think that we should add a Viva station in the OSCE for the basic sciences students?
What we had, let's say, although it's preclinical, but we used to have a couple of OSCEs as well. Which would the application, which would test the application of, for example, knowledge. And if you can use, let's say, what you are calling is Viva, if you can convert into a kind of OSCE, that would be useful. There are a few examples I might be able to share with you later.
Okay, thank you, sir.
May I say something on that, Dr. Iram?
Yes, please.
For the anatomy and physiology, OSPE can be done on a SP by asking the student to demonstrate the action of the muscle or the physiology of a particular thing. And to include the pathology component, a specimen can be added. And for the pharmacology component, the drug is kept in front of the student and he is only asked to write the prescription for it. That means this tablet is to be used for what, although it is not exactly the performance, but it is a recall. But in pharmacology, it's always a recall that he has to know, and he has to add the adverse effects. This is how we used to do earlier. Maybe things have improved and some other thoughts are there. I have that suggestion about this.
All right. Okay. Thank you, Prof. Prof. Aisha from Aisha Mehnaz.
Yes. Thank you. It was a very informative talk, Professor Shermani. One thing always bothered me, I'm an examiner as well as convener at College of Physician and Surgeon at being a pediatrician. One thing always bothered me is the ethical consideration we are not actually undertaking. Like, for instance, in a short case in OSCE, there is a real patient. There is always a shortage of real patients somehow when we are actually conducting an examination.
Right.
But then there are a number of students, like for instance, is a small child who has got some abdominal organomegaly, and there are about 40 students in one row probing and poking their hands into the abdomen. And I find it very disturbing for the child to go through such a ordeal. But if we keep on changing the patient, then of course the findings will be changing and the objectivity will be questioned. So do you have a suggestion?
Yeah, Prof, I fully share your concern, being a pediatrician as well. I think it would be really cruel to ask 40 students to palpate abdomen of a child.
Yeah.
So I mean, we can change the patient. For example, if you are asking to palpate for the spleen, we might have few patients with splenomegaly, which can change after every few students. So that is one. The other is that sometimes we may be more concerned with the technique and rather than the real finding itself. But definitely it would not be acceptable that 40 students are palpating one child's abdomen. So,
but in that case, Dr. Alam, what about having a patient bank so that we have a list of patients? In adults, it is very easy. In children, of course, we'll have to take the permission of their parents. But what do you suggest about a simulator bank or a patient bank when it comes
actually,
to
we have a patient bank which we use both for teaching as well as examination. So yeah, that is a good idea. And certain things, for example, for splenomegaly, we might be getting many patients for example, for this thalassemia. We have number of patients available. So I think with little effort, we can manage such situations. I give you one example, like you were saying, the ethics part. Now, we expect every student to wash their hands before examining the patient. Now, and we have, let's say, some marks for hand washing. Now, there comes a student, it doesn't wash hand and starts examining the patient. So what we do is we stop the student. We ask him or her to go and wash their hands, but we don't give the marks for hand washing to them.
Right.
So in that way, we are giving marks as well as we are taking care of the patient's safety as well. So the things where these things involve, if student has not done, we can ask them to do, but we would penalize them for not doing that.
Thank you.
Right. Yes. All right, I think we are coming towards the end of our session. Thank you very much, everybody, for attending this session and sharing your experiences. I will go through the chat box, and if there are certain questions which have not been answered, I will try to answer them. Now, I have another couple of slides to share with you. As usual, and yeah, the first one is our next webinar, which would be on 26th of September by Professor Dr. Roxana, and this is on best answer questions. The format, the features, and the flaws, and on 26th of September. And as usual, I want to make this appeal to each participant to donate $1 or equivalent amount in your local currency to any deserving individual in your neighborhood or any public welfare organization in your community. With that, I thank you very much.
Thank you, sir.
Thank you.